with chest pain. All right, which is all asked in your uh, papers. So the first question is, uh, a 62-year-old man with diabetes presents to the ED, emergency department, 2 hours of type chest pain, radiating to left arm. ECG shows non-specific ST changes. Initial labs are like this. Coppa is normal, CKMB is mildly elevated, and BNP is normal. Repeated labs at shows significant rise in troponin I. Its cardio biomarker is most specific indicator of acute myocardial injury. So, as we discussed uh, in the session, so uh, I told you center chest gradient to the left, and I've spoken about all the typical features of a acute onset ischemic type chest pain or angina. You have to have those features, and here itself they have given 2 to 3 features, which is completely enough for you to diagnose as an ischemic chest pain. But always there are other features as well, as we discussed, and the ECG and the blood investigations has also sort of given the troponin has elevated, and the CKMBs has also elevated mildly. All right. So there are, as I mentioned, there are various cardiac biomarkers present in the heart cells, which is released when there's myocardial injury and not in ischemia. Okay. In unstable, as I mentioned, unstable angina, you won't get biomarkers increased. It often occurs in end-stage and STEMIs for the reason of necrosis and infarction and ischemia, two complete different things. All right, so I hope you all got it. And then here, the more specific, this is a very, it's a direct MCQ. So various biomarkers will increase, but the most specific is going to be the troponin I. Troponin I is the most. So I'll give you some other information regarding biomarkers. So the earliest biomarker to increase is myoglobin. Okay, again can be asked in the MCQ. So in this case, they have that more specific, but if there's a most earliest, that will be myoglobin. And then CKMB is increased, creatine kinase, and then the troponin. Then only the troponin will increase. So earliest to come is myoglobin, then CKMB, then troponin. But troponin is, as I mentioned, is the most common one, or most specific one. LDH rises late, very late. And also another MCQ point which you can ask is what stays the most? Like suppose you suspect the patient had a myocardial infarction 2 3 days back. What is the best one? Again, it is going to be troponins. Okay. Uh, uh, when you go through these graphs and all, if you Google it, you'll see LDH also goes for a longer time, but actually speaking, troponin is best for that as well. Troponin will be there in the blood for a longer time. LDH will also stay up until that sort of point, but they say troponin lasts much longer, and since it's specific for cardiac injuries also, it's better for you to use troponins to diagnose myocardial infarction, which happened sometime back also before. Okay, so again, all right, troponin is the most specific. Earliest rise is myoglobin, and the longest staying cardiac biomarker is also troponin. Okay. All right, so yeah, with that we'll go to the next question. What is the initial most ECG's change in STEMI? Okay, now again an MCQ which we can be asked. So it's actually what? It's actually hyperactive T waves. Okay, you should know this. Okay, so this can be asked. See, this is your hyperactive T waves, and then after hours, tama you get this ST elevation. So you get hyperactive T waves, and then you have a T inversion. Okay, you see the T inversion is occurring, and then So here, so then you have here, you have this called the Q wave. And week afterwards, you see, the T inversion has also come back up, and what is remaining is the Q waves. Yep, here you don't have the Q waves, no? Here, no Q waves. No Q waves. Here it has started to occur. So Q waves is the definition of a Q wave is the definition of a Q wave is the first negative reflection of the PR interval. PR segment, the first negative deflection in the QRS complex, basically. Yeah. So here you don't have here, there's no negative deflection here, so there's no Q waves here. But here you have the Q waves. And uh, another thing, so the most initial change is the hyperacute T waves, and the one which stays the longest. So to see if to diagnose a patient who had an MI before, the best thing is the Q waves, because Q waves is the one that will stay for the longest. Okay, that is that. All right. Now, regarding inferior STEMI. So, inferior STEMIs. So, what do you mean by inferior STEMIs? Now, you have ECGs. No, you have ECG leads. So, this is lead 1, lead 2, and the lead 3. All right. So, these are your limb leads. All right. And then, these 90. And then you have AB put, AB, AB, and so, yeah. So, you have the ABF, and then which is ABL and AVR. Okay. So always guys, so yeah. So these are augmented leads. These are augmented leads. These are chest, the limb leads, and then you have the anterolateral. The ones on the chest will be the chest leads. So in inferior STEMI, what happens is, so in an inferior STEMI means, now always think like when you think about inferior STEMI, so you're looking. So inferior STEMI means the heart. You have the heart. You just take heart as a box. So if it's like your heart is like that, so yeah, this is my left side. So heart is like that, and sorry, my heart is like towards this side. And if you are like looking from the bottom, if there's an infarction in the in the lower side, lower with the part of the heart which is on the diaphragm, if there's a problem there, if the infarction is there, that is an inferior stem. And anterior stem is if there's problem or in the chest, in the anterior part of the chest or of the heart, of the heart. That is a anterior stemming. Inferior stemming is the bottom. The heart is resting on diaphragm, so that the part which is resting on the diaphragm, is there's any problem in the inferior part of this heart. So now always think. So inferior stemming. What do you mean by inferior stemming? So now see these limb leads. Just think of them as you are looking from these places. Okay. So what is the best leads? What are the best leads to sort of now? This is the heart now. So what are the best leads to look at this part? That's the 3 AVF and 2. 2, 3 AVF will be the best leads to see the bottom of the heart. Here, I think I'll get it. So the best now, suppose so therefore in 2, 3 AVF you will have limb lead changes. You will have changes. Okay. Suppose you have an anterior or anterolateral, then these will be okay. 2, 3, there will be fine. It's because it's the front, no, it's just coming like that into the front, like the changes. So all the chest leads V1 to V6 will be deranged. Whereas now in inferior STEMI, the chest leads won't be affected. or there may be some affection, but the biggest affected will be the limb leads, and it's a 2-3 AVF because we want to see the lower side of this, and the best way to see is this. When you always think about the elite, you just think you are looking from that view. You're looking from this side. You're looking from that side. This is your eyes. Okay, so yeah, like that. Yeah. So yes, that is that. So leads so 2-3 AVF will be affected. That is true. Bradycardia is common. Why? This is very important. It can come in an MCQ. Okay, very important. So bradycardia meaning because uh, your right coronary artery. Okay, so if you try to sort of I'll just give you a slide of anatomy. So you have the right coronary artery, left coronary. The left coronary artery comes like that. Right coronary artery goes around, and it sort of gives if it sort of gives it's the right coronary artery which supplies the inferior aspect of the heart. Just remember it like that, so it's easy. Okay, because you don't need like in detail depth of anatomy. Yeah, that you might have needed in your first year, but now you don't need that amount. Just try to have a rough idea of where it is. So yeah, you have both the right and left coronary. So left coronary will come to the anterior aspect and it will give it will give supply to the anterior aspect of the heart. So if there's a problem in the left artery, left coronary, that's when you will get anterior sort of heart like myocardial infarction. But posterior or the inferior part is supplied by the right coronary artery. Okay, so if the right coronary artery has thrombosis or anything like that, then you will get an inferior STEMI, as we've spoken. The catch or the problem is it's the right coronary artery which supplies in 90% of the patient, it is the right coronary artery which supplies the SA node. So as you all know, SA node is sinoatrial node. That is where our electrical activity starts, no? So if the SA node is not working, that means the heart rate is going to drop. It's not going to work. The heart is not going. The electrical activity won't happen. So therefore, just remember. Okay. Uh, so inferior STEMI. So it's a right coronary artery which gives rise to inferior STEMI, and also right coronary also supplies the SA node. So therefore, you will end up with a bradycardia. Okay, so that's why bradycardia is common. So suppose regarding anterior STEMI, bradycardia is common. That's going to be false because I mentioned anterior STEMI is occurred by occlusion in the left we call left coronary, and left coronary rarely gives supply to the sinoatrial node. Therefore, you can have like you will get anterior infarction, then your chest leads will change, but there won't be any big rhythm changes. There could be a change, but it's not common. It's not common as an inferior STEMI where right coronary artery is compromised. Okay, so then AV blocks are common again. So it is true. All right. Uh, yeah, because again the whole electrical system is sort of um, like given by this right coronary artery. Okay, low BP is uncommon. So low BP is uncommon. That is actually false. So we need to now think what is low BP. It is false. Okay. Now let's see what that means. So um, yeah. Okay. This sort of leads us to a very clinical scenario where a patient with low blood pressure after an MI. So suppose in the ward rounds, you see a patient after the MI, the patient next day has low blood pressure. There are three causes. There are three main causes why that could happen. One is, as you mentioned, cardiogenic shock. No? Cardiogenic shock, where the heart is not working basically, no blood is being pumped out, and that is that. Second thing is something called a right ventricular infarct. not the left ventricle, but the right ventricle. Okay. And third thing is a cardiotemporal artery. They're very important scenarios. So cardiac shock we discussed, as we mentioned in the previous in the session. Uh, right ventricular infarct. So what happens is basically, guys, so you see you have the right ventricle here, the left ventricle here, no? So blood is going to come like that and into the right ventricle. So you need the right ventricle to work for you to get the blood into the lungs, and then it comes back into the left atrium. So if the right ventricle is not working, the right ventricle has infarcted. That means blood will not be able to go to the left, to the lungs, and then come to left ventricle and left atrium, then left ventricle. It's as if blood is not come into left ventricle. So invariably, the patient's going to have low blood pressure. It is not because the left ventricle can't push blood. No? It's not the inability of the left ventricle to push blood. Okay, so it is because if the left ventricle is not enough to push blood, that will give us heart failure and pulmonary edema. But in this case, the blood coming, if the right ventricle is not working, that means no blood can't go anywhere, and invariably no left ventricle will not get any blood, and there won't be any blood going out of the heart. This preload is all gone. So therefore, this right ventricular infarct very important because again right ventricular infarct. Why? Because now again it's a complication of the right coronary artery. If the right coronary artery is gone, that means the right ventricle, because the left ventricle supplies the left coronary, right coronary is by the right coronary. So therefore, in a right coronary artery, low BP is common. Okay, but I'm trying to say is my English might be a bit. I mean, it is, you can't say it's uncommon. Doesn't mean that it's very common, but it's not uncommon because a right coronary artery only supplies the right ventricle. So if you get a right ventricular infarct, you will invariably uh, end up having low blood pressure. And low blood pressure, hence, therefore, in inferior STEMI, so you have to connect these two, no? Inferior STEMI and low blood pressure. The main glue is the right coronary artery. Okay, and you should know this suppressing the systolic node as well. So these three are interconnected to the right coronary artery. That's the main point of this question I'm trying to tell you. And first time treatment in right ventricular infarct is fluid bolus. So what happens is, guys, so just that's a bit of an advanced point. Uh, uh, like basically, you try to push a lot of fluid into the right ventricle, and to get any sort of what do you call contractility, and then get the blood out. Okay, so that's the basic. That there's a bit more complex version of it, but for exam purposes and for MCQ purposes, because it's a bit of an extra point. Can again come in MCQs if you know it, you can jolly well, because a lot of people will again just say PCI or thrombolysis or anything for right ventricular infarct, but that's not the case. It's a fluid bolus. You should give the fluid bolus, and then you have to treat the patient with dobutamine and inotropes. So that's the mainstay in management of a right ventricular infarct. Uh, so just keep that in mind. Okay, that's an MCQ point. You keep that in mind. All right. So that is about inferior STEMI. So I hope you have got the very important question. I sort of made it, and I mean I got it from past papers as well, but some stems I included. All right, okay. So a previously well 60-year-old gentleman constituted by chest pain, ECT, ST depressions in the anterior leads, troponin is negative, treated with heparin. So now we're talking about a patient has constitutive type chest pain, an ischemic type chest pain with ST depressions in the, so troponin is negative and treated with heparin. What do you mean troponin negative? So we know that there's no myocardial infarction. Okay, this is ischemia. As we've spoken multiple times, this not. So what is this? What's the diagnosis in this patient is possibly having the unstable angina. Without any hesitation, can go for uh, unstable angina. This troponin is negative. And treated with heparin, you know how many doses, which we discussed, it is two doses. The rule of thumb is going to be two doses. So, what is the best combination of drugs? So, again, these are like clinical trial based evidence, right? So, uh, uh, usually the patient has to be on dual antiplatelet therapy, as you talked. So, aspirin and clopidogrel, you need them. You need what's the usually you go for dual antiplatelet therapy for 1 year duration, then you go for aspirin, and then you have ACE inhibitors and beta blockers. I told you why it's important to use ACE inhibitors and beta blockers. They have survival benefit and other uh, uh, benefits. And then you have to go for statins. We talked in multiple times why statin is important in the sense like where statin is used in the process of managing an acute coronary syndrome, because statins will give in the sense it will give like a plaque stabilization. As I mentioned, it's the atheromatous plaque which undergoes acute changes. So you want to give the statin in high doses so that the plaque is maintained and any other insult won't come and disturb the plaque. Yeah, that's the main use reason why you use statins. Anything which has statins, this be. This is going to be our answer. So these nitrates, they are just symptom relievers, and if you get an chest pain, there's no point, no, because again in the history, when we discussed at the start, I told you uh, the one of the typical features of an acute coronary syndrome, pain, is it won't be relieved for chest. It won't be relieved for uh, what you call nitrates or simple symptomatic seizure. So there's no point of giving nitrates. Okay, so it's just symptomatic. There's no survival benefit, nothing. Furosemide is not needed in acute myocardial infarction. It's used for pulmonary edema, heart failure, not for. And calcium channel blockers, again, not that they're not like properly for study based for myocardial infarction. So this is the main answer. Okay. All right. So now we'll go to the next question. Yeah, okay, two questions. 58-year-old woman presents to the emergency department with blood pressure of 220 by 130. She is complains of shortness of breath. Examination shows pulmonary edema. Her heart rate is 88 minutes. Conscious and oriented. Which of the following is the most appropriate initial treatment? So for this emergency department, so now this patient, see the blood pressure is 220 by 130. That's one thing I want to tell you. And complaints of shortness of breath and leg edema. So what does that mean? Shortness of breath. Examination reveals pulmonary edema. How did you see pulmonary edema? You get bibasal end crepitations. Bibasal end bibasal end inspirated fine crackles. That's how you that's how you sort of explain, or when someone asks you to describe the features of pulmonary edema, you get bibasal end inspiratory fine crackles. Her heart rate is 88 minutes, and then yeah, she's okay. So meaning the patient is having high blood pressure with acute end organ involvement. What does that mean? That means the patient is having a hypertensive emergency. Okay. A patient with a high blood pressure, let's say above 180 without any end organ involvement, is just a hypertensive urgency, which is usually managed with oral antihypertensives. But in this case, the patient is having high blood pressure with acute end organ involvement. So that means it is a hypertensive emergency. Get that in your mind properly. Okay. Urgency and emergency. This uses oral meds. This uses IV meds. So you can get rid of oral this. Okay. So then you have IV labetalol, IV GT, and IV furosemide. So again, from these three, you should know your theory. That's why I put the table here. So you see, GTN is usually the drug of choice for cardiac problems. For cardiac, so when you want to reduce the blood pressure and you have cardiac involvement, you go for GTN. And you use for labetalol when you have like simple stroke. So you have like a patient coming with a stroke, with high blood pressure, then you go for labetalol. You don't go for GTN, because GTN, if you give it for stroke patient, it will be detrimental. Okay. Um, so yeah, so I want to know that as well. And some like a very what you call interesting sort of thing is this so aortic dissection. You might think aortic dissection is sort of a cardiac issue, so you could go for GTN, but you usually go for labetalol. So that's the only place which sort of goes beyond the card rule of labetalol for neurological ones and GTN for cardiac issues. That is a bit known, but other than that, for neurological emergencies, always, even preeclampsia, eclampsia, they're all involved in brain involvement. No? Like preeclampsia and eclampsia, you will the patient will get fits and all. So that is for labetalol. So for coronary syndrome, this is going to be GTA. And you have sodium nitroxide, which can be used for any sort of things, but it's not freely available. And hydrolysin as well. So here in this answer, the answer is going to be IV GTA. All right. So now this sixth question is going to be directly based on things we've discussed, and very important things. Door to needle time, as I mentioned, is what? 30 minutes, not 60 minutes. Okay. And we've spoken of what door to balloon time is. Door to balloon time is 60 minutes, and if you transfer the patient, it's going to be 120 minutes. We talked it in depth. Subcut morphine is the pain relief of choice. No, I mentioned it's IV morphine, not subcut morphine, it's IV morphine. Again, asked thoroughly in Vivas and in every place. Okay. IV enoxaparin is given 1 hour prior to thrombolysis. I mentioned why, because Tenex place has a low hard half-life. So we need to give anticoagulant cover. But the problem is IV enoxaparin also has a shorter half-life, very short half-life, relatively short half-life, like 24 minutes. So therefore, you can't give it 1 hour before. So if you give it, the proper anticoagulation cover won't be there, and there will be procoagulant factors, and the thrombolysis won't be effective. It will actually cause more thrombosis to form. Okay. So again, we extensively discussed that. So this is not going to be 1 hour prior, it's going to be just before or at the first dose of with the dose of thrombolysis. Repeat ECG is done in 4 hours. No, it's going to be in 90 minutes. In 90 minutes, we go for the ST elevation and see if the maximum elevation has come down by 50%, and like that. So it's done in 90 minutes, 1.5 hours. Then we discussed it. And I hope you all know remember the other features of reperfusion, which is cessation of the pain, and the rhythm I mentioned, which is the accelerated interventricular rhythm. Okay. We discussed of what the features of it is, just the regular rhythm with no P waves. And ST elevations in all is a possibility within 24 hours after MR. So what I'm trying to say, so if you are paying attention, you said ST elevations is seen in what? It's seen in pericarditis. You get concave sort of ST elevations. It's a possibility within 24 hours. Yeah, true. I mean, it can happen. No, I mean, you can't say it can't happen, because usually it happens pericarditis and then happen 24 hours after after beyond 2 weeks. That's what the book says. But anything can happen. But what I'm trying to say is ST elevations mean, when you say ST elevation, all these, that's more or less likely to be pericarditis. That is what I want to say by from this MCQ. So yeah, you can't say nothing is not. Yeah, there's possibility. But yeah, single antiplatelet therapy is indicated post MI. No, it's going to be dual antiplatelet therapy for 1 year, and from that point onwards, it's going to be aspirin lifelong. Okay. So yeah, I hope y'all got an overview uh, on chest pains and all the MCQs. The theory is done, and then the MCQs is more than enough for you to get through your ERPM exams. Yeah, just not MCQs, SPS, as well as 5 as and OSCEs. Okay, all right.